Hello, everyone. This is Eric Glazer, and welcome back to Bright Spots in Healthcare, produced by Bright Spots Ventures. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around the land. Our goal is to identify as many ideas and bright spots as possible so that you can determine if these insights shared today during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not subscribed to the podcast, where each and every episode, like the one you're about to hear, gets dropped onto your device on a weekly basis, almost weekly basis, then I encourage you to do so. Find Bright Spots in Healthcare on Amazon, Spotify, of course, Apple, and anywhere else you consume podcasts. We would love to have you be part of that. If you like the show and continue to like the show, please rate us. Please provide some comments or a testimonial. This is how more of your peers find the show and gather all the great insights that all these experts, like the ones you see before you right now, provide. And that allows us to all make healthcare a little bit better in this country through the sharing of these ideas. Lori from Florida Blue, a recent testimony she posted. I absolutely love Bright Spots. I've learned so much from the episode and I have shared ideas with my team. Thank you for this great initiative. So love comments like that. Thank you all in advance. Our sponsor today, a huge thank you to our friends at Vori Healthcare. If you haven't heard of Vori, they are the only nationwide MSK medical practice with a doctor-led care teams driving to better outcomes. I'm going to tell you a little bit more about them later on in the episode, but if you want to check out how their mission is around empowering whole person care and empowering humanity to lead a better, healthier life, check them out at Vori Health. That's VORI Health, one word, .com. All right, let's get started. Incredible panel that we've assembled today. Thank you all for being here. As usual, we're going to save time with formal bio readings. We're going to post the link to those bios both in the Zoom chat, and if you're listening on the podcast, there should be a link right in the podcast description for you to click on that and get a sense of the incredible expertise you are about to benefit from. Our topic today is the responsible GLP-1 strategies and how you are structuring benefits for both economic viability and proven results for all the members you serve. Our esteemed list of guests, in I think it's alphabetical order: Martin Burruano, call him Marty. He's the VP of Pharmacy Services at Independent Health in sunny Buffalo, New York. We have Dr. Ryan Grant, orthopedic surgeon, CEO, and co-founder of Vori Health. We have Dr. Mark Jansen, family doctor, vice president, chief medical officer of Arkansas Blue Cross Blue Shield. And we have Ilona Smith, the senior vice president of employer government and coalitions at a small organization called CVS Caremark. Thank you all for being here. I really appreciate it. I'm going to start with you, Ilona, and would love to get a sense because we've divided this up. Our producer Jessica Tenzer and I divided this show up into about three segments. And the first one, I want to talk about benefit design and PA programs at a high level. And so, how is CVS Caremark thinking through, life, about just the overall lifetime management of a member, and what solutions have they put in place for those who may benefit from GLP-1s, and maybe give us an overall sense of how it's working and how it's impacting the individual consumer?
Yeah, absolutely. Thank you so much for being here. I'm excited to talk today about some of the strategies and thoughts and we've put into our GLP-1 strategy across our employer book of business. A couple of things. When we look at the GLP-1 strategy, we look at it in two different ways. One, we look at it from a PA, and that's a prior authorization perspective. And then our second way that we manage kind of from a condition management perspective for those employees and members, if you will, is around how do we wrap around a condition management program to help them stay, to provide additional support. Maybe that's a better word to use, to provide some additional support in order to manage their obesity condition. So first and foremost, what we do is we really look at PA. And so our prior authorization program looks at a BMI, and our standard program looks at a BMI of 30. That's what we've used across our book of business for the most part. I will say we've had clients that come to us and have asked us to increase our BMI to 35. We've done that successfully as well. And so the management around that has been pretty phenomenal. I want to point out two things that I think are really important, though, around the PA process. And I know we'll get into this in a little bit more detail as our call goes on. Interestingly enough, 55% of the members that are on the GLP-1s have a 60-day gap within the first year of therapy. So when those members do get approved for the medication, we're finding that about 55% of those members have a 60-day gap in that 12-month period. I think that's really interesting because it kind of shows that there could be some concern around the medications, maybe side effects that they're feeling. And so they go off the medication for a while before they come back onto the medication.
Lida, what do you mean by 60-day gap from the first time they got an infusion to the second time, or from when they get approved into when they actually take the medication?
No, the latter, if you will. So in this case, they get the medication, they start taking the medication, then they take a gap, a 60-day gap, and
Got
then
it.
for whatever reason, they have some conversations with their physician, so forth. They jump back on the medication, but we're finding in the first year there's a 60-day gap
Is
for
that
those
the very
taking the.
first injection, or it could be happening like at the second or third dose?
Yeah, it's there. It's very random, quite frankly. So you would think that it would happen initially, right when they start taking the medication. That's not the case.
Got it.
We're seeing somewhere between 4 to 6 month periods when they stop taking the medications. Well, where there's a gap, if you will.
Okay,
Yes.
right.
Yeah.
Sorry.
No, 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 absolutely no problem at all. Uh, so I want to talk a little bit about the PA process in general. It's a pretty seamless process. They'll meet the criteria, they'll get the medications, they'll start the medications, but we wrap that around a program, a management program. And I don't know, should we go into the details around the management program? Would you like us to talk about the management program as well?
So give us a high level of the management program, and then we'll come back to you on later on in the episode and get more into the nuts and
Yeah.
bolts.
Yeah, absolutely. So the management program is all about, we have different levels of service around the management program. Some of our clients actually want us to take advantage of like prevention opportunities. So those are members that actually meet the criteria to be on obesity medication. Say they're 30 or 35, their BMI is, but they're not really ready to take the medication. They just want some prevention, some management. They want to be able to talk to a dietitian. They want to have that opportunity to have some counseling, if you will. We have that program that's available. Again, it's for members that meet the criteria, but that do not take the medication per se. And then our program goes all the way, as aggressive as it needs to be in terms of the management around the patient once they're on the medication. And so we can talk in depth later on in the call today. But yes, we can go from something very soft, a very soft approach, to a more disciplined approach in terms of management.
Great stuff. Incidentally, folks, we should have time for some questions to weave in and out. Some of you who attend this show live regularly know that often we're jam-packed. Specifically left some time for questions during this episode. So, John, I see your question. We're going to get to that in a moment. I think it's a good question. I'll integrate it in. If you want to help me co-moderate, folks, the Q&A module is right there. Also, and we've been doing this, and a lot of you have really given us positive feedback on it. I am typing vigorously during this episode, and so is Jessica Tenzer, and we will collect all of our notes. They're just our notes. They're not professionally done. I guess we're professionals, but we're not great. But we take great notes on a Google Doc. If you want our notes as a byproduct of this episode, I'm going to ask you the favor of when we send out the feedback form 45 minutes into the show, so right around 9:45 Pacific time, if you could take that 3-minute survey monkey giving us feedback and episodes we should cover and how well we did, how we could be better, we will send you a copy of our notes as a thank you for that. So anyone that does that, you'll get an email from me in just about 40 minutes, 35 minutes. If you fill that survey out, we'll get you those notes. Thanks for that, Ilona. I really appreciate it. That was really good. And I do have some follow-ups, but I'm going to wait. Actually, let me actually, there's one follow-up specific to this answer that I want to make sure we get in. For the 60-day gap that you mentioned, what percentage of members lapse completely in the first year for those who kind of return uh, and do it differently?
37% of members on a GLP-1 actually drop off of therapy completely
Got it.
in the first year.
I'm sorry, say that one more time for my notes.
Sure. 37% of members drop off of therapy completely after the first year. That's what our book of business is showing. So I just want to be clear on that. And our book of business represents October 2022, I think, all the way up to mid 2023.
Right. Okay. And we don't know all the reasons yet, right?
We don't. We don't. We're doing some work on that now, but we don't know all the reasons at this point. Some of our indications when we saw the drop in therapy and even actually the drop off of therapy, the 60-day gap that I mentioned, and also the drop of therapy, we we wanted to know whether or not there had to do with fluctuations in the market in terms of supply. And so we had, yeah, everybody knows we had some supply issues during that time period. So these are our numbers thus far. We haven't dug in deep enough to kind of identify if there was an issue with the supply that's causing these
We're going to talk about supply at the end, as you know, but I can't wait to hear your answer on that.
numbers.
I want to bring in my friend from the Buffalo, New York area, Marty Burruano. He's the VP of Pharmacy Services at Independent Health and a proud member of Bill's Mafia. So, Marty, how is Independent Health using evidence-based programs to create a benefit design that works for your MA and your commercial business? And what are some of the important variables you're taking into account and your overall process and system for checks and balances there?
Yeah. Well, thank you for having me on the show as well. I suspect it's very similar to what Iona described because as far as overall programs, and incidentally, we are also seeing about a 30% drop off rate. So that seems relatively consistent. And I do suspect some of that was due to the shortages at the time. So we're going to keep monitoring that adherence, although it's not that much different than our diabetes drug adherence in general anyway. But we do at Independent utilize an evidence-based weight loss program approach very specifically as a primary requirement through our prior authorization process. We were encouraging participation into an evidence-based lifestyle management program, either through vendor, community-based, or provider-driven. Several of our provider practices have, nutritionists on staff, things like that have their own programs. So we don't limit it to any one program, but we do require significant documentation from the provider to document the elements within that program and what they're doing around what we call the three pillars. We're looking to incorporate nutrition, the hypocaloric diet. How are they managing that? Exercise programs, what exercise programs are engaged in, and then if any behavioral modification programs are in place to support those members, patients, because we really believe that this evidence-based approach supports the family journey and a healthy journey, to promote, health, promote better outcomes, and modify, healthy living in general. So that's kind of like. And that's the prevention piece too. And that's also that's the bedrock or the base for making sure that we're helping the provider manage our members by driving this, as we do have to take a cost-effective approach to this as well. And our primary care providers are in value-based risk arrangements too. So they're responsible for their total cost of care. So it encourages them to utilize these kinds of programs, ahead of prescribing, more costly medications like GLP-1s, using other interventions first, such as an evidence-based weight loss lifestyle management program.
Let me ask you a couple of those follow-ups to that. So what I heard was, one, there's a pre-auth program. I don't know if you shared with me the BMI or not. There was a behavioral change.
I'm getting to that.
Oh, sorry. There's also
Yeah.
behavioral change requirement. I'd love to. So one quick follow-up. Could you give an example of one of those behavioral change kind of requirements? And then the second is, how critical are you guys seeing the role of the primary care doctor in all of this? Because that's something we probably don't talk enough about. So just two quick comments on
Yeah.
those.
Let me take the latter first, because we do basically require the management through a primary care provider. And our physician philosophy is around primary care provider being the quarterback of that patient's care. So it's primary care directed. And with that and with their risk arrangements, it promotes that cost effectiveness, and prescribing and judicious prescribing, hopefully, within that. So that's the primary. And then we require in-person visits as well. So in-person assessments by the primary care provider are a requirement. We don't allow assessments in a telehealth environment. They have to see their primary care provider. and have follow-up assessments with their primary care provider. So on the first part of that question, we definitely look at, what behavioral modification is it? Is it psychosocial? Is it physiological? What support do they need outside of primary care, possibly, to support any behavioral needs they need in order to change or build a lifestyle conducive to healthier habits.
Right. And so the second part, as far as the lifestyle change requirements, and then you were going to mention the BMI requirements.
Yeah. Oh, yeah. The BMI. So our BMI requirements, are currently, 30, 27 and 30 into comorbidities, but we are changing that 1 to a BMI of 40, a greater than 40, with comorbidities, in an effort to address the most at-risk population first, to just ensure that we're kind of right-sizing utilization of this. I mean, it is uncontrollable utilization. But on the back end, we also have programs built for our members that are 30 and above, through other obesity management, targeted interventions as well, which I can talk to later as well.
And real quick about the lifestyle change requirement, there was I remember when we were prepping, you had mentioned to me a program that you don't cover, but you want people to be part of as one of the ways to prove, as one of the options for members to prove their lifestyle change. Could you get into
Right.
that? Yeah.
Yeah. So when I mentioned, it's either it could be a vendor program, could be community-based, could be physician-based. One of the vendor programs that we offer is Weight Watchers, right? So they could enroll in Weight Watchers. We do not cover it as a benefit, but most of our commercial plans have what they call healthy options benefits, where they get X amount of dollars to enroll in certain programs. So we do support it through through our wellness offerings in our commercial or employer group line of business, but we don't directly pay a membership for it.
That's really interesting. I mean, I know that's actually forcing them to put a little bit of skin in the game,
Right.
and so Weight Watchers is certainly a bright spot in healthcare. It's stood the test of time, so that's a really interesting way of leveraging. You're gonna say something, or you? I want to. So I love what I'm hearing here, and I think it's a good transition into sort of talking about integrated whole person care, because everyone's alluding to this with a little bit of mental health. Primary care is the quarterback. There's all kinds of things we have to worry about. So I want to bring in Dr. Ryan Grant. He is the CEO and co-founder of Vori Health. He's also an orthopedic surgeon. I want Ryan to talk about how you think about whole person care when it comes to the members who may benefit from GLP-1s. And I know we haven't talked a lot about fall prevention and MSK issues tied to folks who may have diabetes, who are also comorbid with obesity. Could you share maybe an example of how a health plan out there is innovating around MSK, GLP-1s, and obesity in general?
Thanks for having me. And I'll start with your first question of really taking a step back to playing off of some of the things that Marty said of whole person evidence-based care is essential for GLP-1s, because obesity or being overweight doesn't exist in a vacuum. There's, however you want to describe it, a vicious cycle or connections between obesity, immobility, musculoskeletal pain, mental health, cardiovascular disease, type 2 diabetes, and the list goes on. And so there's no question that GLP-1s are a powerful solution for weight loss. But sometimes what we find is, you take a step back, that's sometimes missed in the community, is they're a tool. They're not the whole toolbox. And so this is especially important when it comes to caring for individuals who have both obesity, musculoskeletal pain, because there's also some side effects. There's the typical side effects of nausea that some people will stop, that come in early on. But then in the literature, you're getting more and more talks about loss of muscle mass, all known as sarcopenia. The medical literature is conflicting about, is that true or not? But what we do know from the medical literature, that even if you have someone who just fasts, just normal fasting, they'll lose fat and muscle mass if there's a rapid weight change. So it's likely that a similar phenomenon will happen where people, as they're losing weight, will also lose some muscle mass. Now, why does that even matter? So if you look at the Medicare Advantage population, who have a much higher risk of falls, and that's a CMS star rating, as muscle mass goes down, it's well known that the risk of imbalance and falls goes up. And 95% of the hip fractures in the United States are from falls. And 1 in 5 hip fractures in the United States dies in the first year. And so if you look at a survey of 13,000 Medicare beneficiaries, 22% of them have fallen in the last 12 months. At least 10% of them have fallen multiple times. And so how do you mitigate that risk? We really think about this on that whole person. So on our Medicare Advantage plans, we screen 100% of the patients for fall risk. In one of our clients, we found a 16 to 20% real risk. Though some of those MA plans are also doing mock cost surveys to also further identify those at risk and then put them into a holistic program that includes, if there is a weight component as well, sort of some of the similar things that Marty's talking about of nutrition, mobility, exercise, strengthening, particularly if you're going to try to have someone on a GLP-1 who's also a little bit frail. If they lose a bunch of their muscle mass, they actually can start to fall more easily. And so exercise becomes a very strong component and PT into that. So there's a clear overlap between muscle loss, falls, GLP-1s, weight loss, and then on the fall side, also just osteoporosis. Sometimes GLP-1s have been shown to be protective for that. Sometimes they haven't. Diabetes is known to be not protective for osteoporosis, osteoporosis being brittle bone. That's what causes most of the mortality and morbidity post-fall. If someone falls, they break a bone. It's not normal to fall and break a bone, like a hip. That means you usually have bad bone until proven otherwise. And so putting that all together into an evidence-based, thoughtful plan about what's going on with the member. And then we also then infuse a cognitive behavioral therapy model, change requirements. Otherwise, GLP-1s used in isolation is no different than someone trying to diet. And once they stop, they're going to revert right back to where they were.
And Ryan, is there a health plan specifically that's kind of incorporating all this and making this all kind of, and I don't know if you could mention my name, but just at least outline what, real quick what the program looks and feels like?
Yeah, one of the Medicare Advantage plans who we've worked closely with this on would be Select Health. That's Intermountain Health Plan out in the Utah market. And so fall risk there in terms of screening 100% of their folks. And we'll continue to double down on that there. But yeah, there's lots of different overlaps, and you'll see that in the stars ratings, and then that can then feed into osteoporosis is another star rating, particularly in postmenopausal women. And so it starts to all get connected in terms of just maximizing outcomes.
I have a follow-up question I'm going to start with you on and keep the questions coming in, folks. But real quick, so one of the pieces that prompted our team on our end to want to do this episode was an interesting study and paper that I guess I'll call a white paper on integrating GLP-1s into the future of MSK care. And it gets to a lot of the things that Dr. Grant was just speaking to. Vori did author it, but there's a lot. If you're in product or you're on the clinical leadership team out there and you're looking to expand how you are creating your benefit design and your product design to support members who are struggling with obesity and comorbidities, I highly encourage you just to read this piece. It's not really a sales piece. It is branded with Vori, but it's not really a sales piece. It provides you a lot of good information that could help further your ideas and how you want to make a more comprehensive a program that's going to provide more value both to your members, your employer groups, and also your own business. So if you want that PDF, I'll send it to you so you don't have to go through any gates or anything on the web, and I'll send it to you after the show. So Jess will put a poll up there, and people that want that piece, we will send it to you. Ryan, quick question, and then folks, I may have a few other people if you want to jump in. I'll call it a jump ball after Ryan goes. With the recent CMS memo that came out on GLP-1s, there's a missing component. What is the cost avoidance with them, and how do we understand this as it relates to ROI? I don't know, Ryan, if you want to start.
That's a nice loaded question. Got the little magical button. Well,
By the way, I'm going to throw your team under the bus. They wanted me to ask you that. So
no, that's fine. No, no, I would expect CMS to eventually approve it. Right now, we know CMS does not cover it for weight loss. It's just for diabetes. But you have to make the argument where if the government or society has agreed to pay for all of the sequelae of being overweight, diabetes, cardiovascular disease, and everything that comes from that, then it's a hard argument to say that we're not going to cover things that can help prevent those downstream. So I would expect over time that eventually that gets covered, written into policy, which then will put pricing pressures into a free market to drive drugs down, generics, things will come off patent, and you'll start to see those come into more mainstream. The question still becomes, though, is what we don't know is you have, like, as you heard, 37% drop-off rates. How are they used responsibly? What is the long-term sequela? So if you have people who aren't using them, what's their risk of developing cardiovascular disease, diabetes, and the natural history, compared to as this is used as a comprehensive toolkit? What happens to that ROI? It's really going to become more of a longitudinal look. And I think if you're thinking about Medicare Advantage or Medicare, you really have to be thinking about things in 3 to 5 year time spans, not single years. And so, not trying to be cagey, I would expect there to be an ROI. I just don't know if you'll see it in the first 12 months per se, given the current cost of the drugs.
Got it. And costs are coming down. I'm sure everyone sees a lot of these alerts and a lot of these articles. I want to bring in Dr. Mark Jansen. We've sort of like a good field goal kicker. We've tried to ice him a bit, but I know he's ready to go. He is the Vice President, Chief Medical Officer at Arkansas Blue Cross Blue Shield. Mark, what are some of the ways you're thinking about it? I mean, you've heard obviously some comprehensive PA and med managed programs from your peers up here on the panel, but how are you thinking about value-based care and obesity and medication management? And are you how are you planning to address this down in Arkansas?
Well, historically, our plans have not covered medications for obesity management. And as the GLP-1s have come on, that's continued to be the case for our fully insured plan. Most of our ASO, administrative services only, or self-insured customers have that same policy. Ryan said something very important just a moment ago regarding longitudinal relationship to the outcomes. And so anytime you're working on a health problem of any type, be it hypercholesterolemia, if it's diabetes, if it's obesity, managing those problems well. And that's the M word that's been consistent in this discussion. It's not just simply access to a drug. You don't just give a drug to someone and walk away. You have to have the management. If you don't have the management, then you really don't have care. And so the ROI question is a significant one to ask, because how long, from a health plan standpoint, how long will that person be part of your plan? They're going to be there for a week, a month, a year, 10 years, 20 years. You catch somebody early in life with obesity who's going to be on one of our commercial plans for 2 decades, the ROI discussion becomes relevant. If you're going to be working for a large retailer and the typical span of time they're employed is 3 years, going to that retailer and talking to them about covering this type of drug, when the benefit might come later to a different insurance plan or even perhaps to the government, is something you got to think about. So the value of this value is going to be medical benefit. It's going to be time driven. It's going to be cost driven as far as the medications go.
Got it. Thank you. Thank you for that. Any sense of how you're thinking about, value-based care and putting, partnering, carving out sort of a management program that allows providers or partners to take on some of the risk and management?
Yeah, Marty talked about primary care orientation. We're primary care oriented as well. I was a family doctor in rural South Arkansas for 27 years and then taught 6 years up here at the University Medical School. And what I know, if nothing else, is that family doctors have too much to do with too little time and too many people to see. So the idea that the typical family doctor is going to be able to be involved in a comprehensive management program that's going to include observation of exercise, looking at dietary habits, making sure medication adherence is there. And oh, by the way, I also need the list of 9 other things they came into the office with. It's going to be almost impossible. It's aspirational for typical family doctors to do that all by themselves. I think what we're looking at is going to be a partner that helps us with that. And just as, a BMI is just a BMI. Obesity is multifactorial. It's genetic. It's psychiatric. I mean, it just goes on. And this is really, everybody throws around the term personalized medicine. This is the perfect space for personalized medicine. And I don't think that our individual FPs are going to be able to do this. So we're looking at perhaps a partner that comes with us. Everyone is different. Do you require an exercise program on the front end? Are you
Right.
trying to see if somebody is agreeable to lifestyle changes? Are they disagreeable to that? And really, you're just going to jump right in with GLP-1.
Ooh, I lost him. You guys still hear me, right?
I can hear.
Affect
Hey, Mark. Mark, we're losing you.
change in BMI, and then introduce the lifestyle changes on the GLP-1 for.
Yeah, we lost Mark. You were breaking up. I'll come back to you a little bit later on in the show.
Okay, am I back now?
You are. I put you on mute because
Where did you lose me?
lost you about 20 seconds ago. So I'll come back to you in a little bit. I want
That's
to
fine. That's good.
tell me a little bit more about the CVS Caremark, and we talked a little bit of. Now we're really into sort of longitudinal care. How important is lifestyle factors and modification before prescribing GLP-1s, and how are you guys thinking about that and approaching that? If we get more into the details of that.
Yeah, I really appreciated the comments that Mark made because I totally agree. In fact, I agree with everything that's been said so far and feel like Caremark's aligned in the same way. I mentioned earlier we have a prevention module that kind of talks about those things before a member even gets onto a GLP-1. What can we do? What kind of counseling can we provide? What kind of nutrition support can we provide? What kind of services in terms of weight loss conversations can we have with them prior to even going on to a GLP-1? So we take that to heart. We're very serious about it. And we have a large number of clients that have adopted a prevention program before actually moving forward with prescribing medications. It's been very successful. I will tell you, in terms of the success the program has realized, our weight management program, just some stats to throw out there. We had 11,000 members enrolled in a particular program. We saw some pretty significant success from the program. 89% engagement rate in the program. And then we also saw about 89 to 90% satisfaction rate from the program as well. That's pretty significant for 11,000 life opportunity that we were presented with.
Love that. That is really impressive. Let me throw a question out. And I will throw it out first at since you're on the mic, Ilona, I'll start with you, but anyone else could jump in. Does remote patient monitoring, how is anyone thinking about that and integrating that into the management of the member?
I think it's a component that we have to definitely take advantage of. Remote patient managing is very important. We've got regular check-ins with members. We have an app that allows them to kind of provide information, virtually to us, if you will. The scale's hooked up to the app, so they can get on a scale. We can show what's going on. We can see what they're eating in terms of that as well. So I think it's a huge component of the weight management program.
We at Independent Health also have provide an app through a company called Brook that provides for remote monitoring as well as nutrition, weight management, exercise, all through health coaches and so on that help manage those as well in a digital basis.
I think remote is critical because you look at states like Arkansas, where it's 40% rural. The rural population is disproportionately more obese than the urban population, probably less oriented to lifestyle exercises and such. So I do think that a remote option is pretty mandatory to have if you're going to reach the rural population.
Yeah, we have similar thoughts. We think about it's just care. It's not in person versus virtual or RPM or CC. It's just care. So we have a lot of members who are rural or don't have cars. They're never coming in person anytime. And so we find that as we think about virtual, in person, and just meeting the members where they are, what's being done, whether it's virtually or in person, is what's most important compared to the modality in our mind. Sometimes we found when plans have sometimes mandated in person that it's actually put more barriers to some folks that live far away and don't have cars. And so it's just understanding the member mix and thinking about what they're going through and meeting where they are. So it's just care is how we think about it.
I want to take a quick pause for a moment. I'm going to warm up. I want to take one last question from the audience. I'm going to throw it at both Marty and Mark, representing the health plans here. And this comes from a chief medical officer and former guest of the show. And she asked, what are the changes to PA requirements for higher BMI in UM? And is this leading to more bariatric surgery requests? So think about that. I'm going to come to you in a second. But I do want to tell everyone again more about Vori Health, who is the sponsor of this episode and a partner of Bright Spots, and one of the, in my opinion, shining stars in our space. They are a nationwide specialty medical practice, and they're created to help individuals experience life without pain and unnecessary surgery. Ironically, they were founded by two surgeons, and they fundamentally are trying to change how back pain, joint pain, and all MSK is being treated. Instead of bouncing around the system, we've talked a lot about longitudinal care already. You have a holistic team focusing on non-operative specialty physicians, PTs, coaches, and dietitians, all in one place, taking care of that individual member, all rowing in the same direction. They're the only nationwide physician-led solution offering true hybrid care with appointments available both in person and virtually. So a really cool program, really interesting way of continuing to maintain costs tied to obesity and comorbidities with diabetes, obesity, and all the other comorbidities we're talking about. Really interesting way of differentiating yourselves out there when you're selling into groups. So I encourage you to learn more about Vori Health. They are reducing unnecessary surgeries right now by 78%, lowering musculoskeletal spend up to 4-to-1. Claims validated ROI there when we're talking about that, and getting people just back on their feet faster. So VoriHealth.com, check them out. If you take that feedback form, I encourage you to do to get our notes and all the notes that we're taking. You could request a introduction to either Dr. Grant, who you see there, or his leadership team. I know many of the players there because I've been working with them for a while. They're all great people too. I know the benefit of just picking their brain and learning more about MSK and obesity. So going back to that question from the audience, so Marty, have we seen any increase in bariatric surgery? And then I'll go to Mark and see if he's got a perspective on that.
Well, no, not yet, because we're not implementing this till 1/1. But on the other side of it, with the increased utilization of GLP-1, significant increase of utilization of weight loss GLP-1s, we have not seen a significant increase or decrease in bariatric surgery. So I'm not sure which way it's going to go, but that's something we'll definitely be monitoring.
What about down in Arkansas, Mark? Same, different?
Maybe a little different. We've not, our prior auth process has relaxed. I would use that word on bariatric surgeries. I think the research is showing that the ROI, as far as significant impact on comorbid conditions, occurs at about the 2-year level post-operatively. And so that actually is becoming, if I could say, more standard of care. I do think that as GLP-1s drop in price, as Marty said, it's going to be a little bit of a horse race to see, are GLP-1s behind, and bariatric surgery as established has been around for quite a while. The vilification of bariatric surgery is going away because the surgeons have simply got a lot better at doing what they do, much like with any other surgical procedure. And so I'm impressed with what I see with good bariatric surgeons and the outcomes that they have. And I'll be anxious as GLP-1s come down to be sure that members have that option. Some are going to go surgical, some are going to go medical. I think if I had a choice, I'd rather try drugs first before I was cut open, but that would be my decision, might not be everyone's.
Right. Marty, I want to come back to you. I want to talk, you talked a little bit about that Brook Digital program. How are you thinking about these evidence-based approaches? And are there things that you're doing in other areas of your business, in other sort of disease state areas, other clinical areas that are supporting members, and you're able to now take some of those successful components, call them bright spots, because that's what they are, and move them over to weight loss? And so
Yeah.
talk a little bit about what you're doing there.
Yeah. At Independent Health, we have several current interventions for obesity in general, with or without diabetes, but just for obesity in general, and a care management team around that includes pharmacists, health coaches, nurse case managers, and physicians, and we do significant member education, both in person, website, and Brook through our Brook app. We do proactive targeted member outreach for patients, for example, to enroll in our diabetes prevention program. We have a specific diabetes prevention program for which which is targeted to pre-diabetics with a BMI of 30 or greater, with 2 or more comorbidities, and the various tools we provide those members, including the online app, which has a diabetes prevention component built into it. And then I talked about, obviously, our weight management programs, and specifically when we're talking about the primary care community, I just want to clarify that we're only requiring that in-person visit for initial assessments. It'd be hard to do an assessment based on member self-submitted data. So that's kind of where we're getting with that. And then also with the wholesale holistic look at the patient, from prevention, lifestyle, behavioral modification, exercise, and then for obesity in general, and then is there utility for medication beyond that? So taking that kind of algorithm approach, and then we also have several employer group programs around. We call it FitWorks, where their employees are incentivized for lifestyle, weight management, healthy living options.
What's it called? What's that called, and how does it work?
It's called FitWorks.
FitWorks.
Yeah.
Okay.
And it's an employee-based app where the employee is incentivized to participate in quote unquote FitWorks.
Yeah.
And which includes it's basically a health risk assessment and what they need to do within that assessment. And then the employee gets various incentives on how they perform within those. They earn what they call FitWorks points, and then they earn incentives based on that for healthy living habits.
Well, okay, so FitWorks points converts to sort of spendable dollars to buy stuff.
Yeah, fresh fruits and vegetables, all those kinds of things. Yeah.
Okay.
And then we also built an obesity KPI dashboard, right? We're talking about how are we going to measure this stuff, right? So, looking at their A1Cs, their blood pressure, their hyperlipidemia, is there going to be decreased hospitalization with chronic conditions? Obviously, this is long-term for most of it, right? We've already seen in our diabetes prevention program decreased A1Cs. That's more of a quick win. But as far as, the chronic and disease conditions, that's going to be more longitudinal, obviously. Yeah. So really, we're just looking to bridge obesity management with appropriate medication utilization. Is really the end in mind.
Let's I want to shift here the last 15 minutes because we got some really where we could go with the future and opportunities for further innovation. Real quick before we do that, I just want to give everyone a heads up about what's going to be dropping. With the holidays coming up, we have a lot of we're not going to do any more live episodes this year, but we're going to do, I've already recorded a bunch of episodes that will drop on what we call our bye weeks. So we're going to have, first of all, later this week, you're going to get a bonus episode around an inside look on Health Impacts 2025, which is a conference up in New York City. And there's a chance actually you could come meet me and some other folks at a discount, but that'll be a fun way of just hearing about what's going on in Q1. I have a episode with the CEO of the United States of Care, which is a very interesting organization down in DC, and she and I spoke at Health. Really cool episode and conversation dropping. And I have an episode that I'm going to be recording next week with 2 executives at Highmark talking a little bit about their digital mental health approach and their post-acute care program. A lot of bright spots there. So subscribe to the podcast, get access to all those episodes. We'll also email you if you want links to the video versions of those if you want. So all coming up for Q4 for Bright Spots in Healthcare. Ryan, I want to talk the near future now and how product owners listening and clinical leaders looking could be rethinking their design strategy to enhance the value and impact of these programs. And folks who are living with hypertension and or diabetes, along with comorbidities with obesity, and how can how can they be thinking about product design and benefit design? And what are some things that could allow them to have a more commercially viable, economically viable solution?
No, thanks for the question. It's going back to that whole person approach, or as Dr. Jansen said about this is a great place for personalization. It's true. As you think about that toolbox of obesity or weight management, completely overlaps with diabetes. GLP-1s are one of the drugs that are used to also treat diabetes, and cardiometabolic health, and musculoskeletal, and cognitive behavioral therapy, mental health. They're all used or should be used in the treatment of a comprehensive program because they're all connected. So as you put on weight, you increase musculoskeletal pain, you increase your risk for diabetes, you increase your risk for cardiovascular disease, and then those become a vicious cycle. So it's taking a step back. And I think to your point of even just back to the packaging, the news has done a great job to push GLP-1s is all over the place. But is that the way we should be incentivizing it or calling it as a medical society, where we are focused on just the drug versus the treatment of a person, and that's being a tool versus a toolbox. Um, and then I think, as you heard here on today, it's GLP-1s just have to be part of that toolkit. So it's imperative that there's education to the member. It's imperative that there's an exercise component. It's imperative that people are assessed for the needs for cognitive behavioral therapy. There are people who have really bad associations with food. They get super stressed and they stress eat. GLP-1's not fixing that. So you have to deal with that. It's really easy in the United States to get access to bad food. We're the most overweight country. It's where fries are cheaper than lettuce. And so also just taking a step back of how do we get better food to people? Because GLP-1s are not going to fix that either. And so just like I like to think about, like alcohol, drugs need to be used responsibly. And then those in charge of benefit design, I think, as you heard here today, what are the appropriate incentives, disincentives? So you've heard people using some fit works, as Marty talked about, to incentivize. People are motivated by carrots and sticks. So where do you reduce their premiums by recognizing appropriate behavior change? Where do you put GLP-1s, more of a stepwise approach where it's further down the line to show that the person actually can make lifestyle change and make sure that everybody knows those pros and cons, particularly the members. Nobody likes surprises about side effects. You heard about the 37% drop off. Is that supply, side effects, adherence, participation, cost? If they're going to drop off anyway, it'd be nice to know who those are and why to have other strategies before spending all that money. And pharmacists can really be great partners in this. And so at the end of the day, you don't have to build a complete program from scratch. There's tons of evidence-based medical practices who are doing this with great results. So it's really choosing the right partners with the right benefits.
Hey,
Yeah.
hey, Eric, I want to support something Ryan just said too.
I knew you would. I was going to go
Yeah,
right.
okay, all right. Yeah, I told you I'd try to be quiet, but I can't stand it when he threw that bone to me.
Go
So,
ahead.
so we eat too much of the wrong stuff. We have to eat the right things in moderation. And like he said, fries being cheaper than lettuce. But exercise is so intimidating to people with obesity. And the idea that you're going to exercise your way to weight loss is really a fallacy. Weight loss is only going to be maintained with exercise. They need to know what they can do and how they can do it. What obese person is not already orthopedically challenged? The answer is they all are. And so when you have a program like Ryan's, where the individual can be introduced to the appropriate type of exercise that will be sustained and maintained for life as a lifestyle, that's a critical component to maintenance.
Love that. Let me ask you a follow-up to that, Mark, and I'll ask some of the group this. If there was a wraparound program that came with your GLP-1 management strategy tied to lifestyle modification, let's say it was virtually based, because that's the only best way to scale it, and it was strictly around tiny habits, hat tip to BJ Fogg, and just other lifestyle mods, would that be something that you guys would all consider? I guess I'll ask Mark and Marty first, and then I have a question for you, Ilona, so you could answer that as a launch into the question I'm going to ask you.
Yes, I would say, and the reason being that, engagement is one thing, getting people started is great. Maintaining the process over time is the hard part. And so I think you have to have customization so that whoever is going to be engaged in the program, you stylize what's going to impact them and make sense to them to maintain it over time. Marty?
Yeah, I definitely agree. And we're continually evaluating a number of vendor programs currently to help augment and support, you know, all those elements, especially those three pillars, um, to provide members with those options. So
Marty,
that
can you remind everyone the three pillars? Just do my job for me.
the nutrition, exercise, and behavioral modification.
There's really
Um,
four because sleep's the fourth, right?
yeah, true.
Okay.
Healthy living, I guess.
Yeah.
Hard to
So
get
yeah, so
hard to get sleep if you have sleep apnea because you're obese. I'm just saying.
there you go.
Good stuff. Good stuff. So I want to ask the same question to you, Ilona, and then a follow-up would be like, what's the future for GLP-1s in general, broader clinical impacts? Because we are talking a little bit about the risks associated with the drug, and of course it's invasive and there are side effects. But at least a lot of the people I've talked to who have many more letters after their name than I do in degrees, and do believe that the safety profile for this drug's pretty strong, and there's all kinds of potential efficacious impact of beyond just even appetite suppression. So first, what do you think about just in general, that first question around, and then secondly, around lifestyle management and wraparound and habits, and then secondly, what's the future for GLP-1s?
Yeah, I probably tend to agree with what's been said already. Our Caremark program does a lot of the things that have been mentioned here on the call. We do the kind of the wraparound lifestyle program, trying to get those people engaged in all of the activities that have been mentioned here, weight loss, exercise, nutrition. All of those items are so important in order to maintain a healthy lifestyle and management of the drug. A couple of things to answer your question about where the future goes. There's so many different opportunities with these GLP-1s. We know we talk about sleep apnea. There's cardiovascular indications now that are going to be used for GLP-1s, kidney disease, liver disease. This is just going to continue to grow in terms of these medications being used for other indications. I think there's a big opportunity for a total cost of care, kind of looking at total cost of care. What does that look like? When you mentioned the bariatric earlier, the first thing that came to my mind is we've seen on the medical side an increase in cost. So while there might be this, decrease in terms of weight loss, and there are some side effects from taking these medications, right? Blockages. We've seen an increase in more ER visits. So I think we need to look at it a little bit more holistically in terms of not necessarily the bariatric surgery, because that's important, but like where's the increased cost from a medical side coming from with these GLP medications around, the blockages that we've seen and some of the items that have been mentioned as well. So yeah, I think there's a lot.
Is
I'll
that
stop.
like, no, I have is that the number one, is the blockage the number one, what I'll call cost potential adverse event as it relates to cost go? Let's assume that we look into the future in 4 years and the cost of the drug now have gotten low enough where the math just works really easily for all those who are, and PA programs just look fundamentally different because the math looks better. And then all of a sudden we're either going off label, or maybe Novo Nordisk, Eli Lilly, and everyone else has gotten approval for some of these things like you mentioned, kidney, liver disease, etc. What are some of the, as we're planning, as we're trying to get ahead of it and go where the puck's going to be, how should we be thinking about our strategy with benefit design to encourage the use of these drugs when appropriate? Let's assume the costs are down, versus also worrying about where it could increase costs due to some adverse side effect.
Yeah, that's actually a great question. I don't know that I know the answer to that because it's still to be determined. I think you bring up a good point. I think there's going to be a market where it's going to flood. The market's going to flood with GLP-1 products. We'll start seeing that happen probably at the end of this year and next year, where we'll have more entrants into the market. We'll have some generics coming into the world as well. So the cost of these products are going to go down, but it makes one wonder if the medical side is going to go up in terms of some of the items that we spoke about here. So I think that's to be determined. I don't know where we're going to go with that yet.
Got it. And I got one more question since I have you on the hot seat here, and it's around. And by the way, folks, you now have that survey in your inbox. So before you leave us today, why don't you go to your inbox and give us that survey, and we'll get you the notes. But question I have from an audience member is, can you comment about compounding pharmacies
Mm.
products? Are these the same kinds of products, and why is the pricing so different?
Yeah, there's not a rhyme or reason on the pricing. I just want you to know that. So we've done a lot of work around the compounding pharmacy aspect around cost, whether it's the trizepatide or the semaglutide products. So our research is about 200,000 compounded prescriptions have been dispensed this year in 2024. You all know, I'm sure, that Lilly and some of the manufacturers are going after these compounding pharmacies to try to shut them down. They had the opportunity because they created that niche in the marketplace when there was a supply issue. I don't know that compounding is the way to go. There's no real regulation around compounding. We don't support compounding pharmacies in terms of offering that to our members as an option. As an organization, we don't.
Even,
We also
even, even with the dramatically reduced costs right now, you guys are
we
you
don't.
obviously pharma agnostic, so you're basically saying that it's better use to spend more money on the branded products right now.
Yeah, well, there's a lot of copay cards, incentive programs that are out there by these manufacturers that lower the cost. We also have clients that bore a percentage of that cost as well. So it's really up to the client to make that determination on how they want that coverage to occur. We don't have any clients in our organization today that allows the compounding of the GLP-1 prescription for their population today in our organization. There's also a concern because we found that the product that they're utilizing is coming from China, and we do not feel as an organization from all the research we've done that we feel confident in the product that's coming from overseas used as a compound agent. So again, that's our position as an organization.
And for all those reasons, we follow that exactly the same. Yeah.
Thank. Okay.
Agreed.
Mhm.
Gotcha. Okay. Really interesting. 'Cause I was going to actually come to you about that as well, Marty, seeing that you're in a space. Okay, let me ask you another question, Marty, and this was something that came from an audience member. What are are the benefits designed to keep patients on the drug long term, or are you thinking strategically, okay, how do we get them off the drug? Because you talked a lot about the PA programs and some of the things that would allow them to be successful once they're on the drug.
Mhm.
But is the premise, okay, we got to keep them on the drug, the cost will come down, it'll be affordable, and all the other savings tied to lesser risk, tied to some of these severe comorbidities will pay for itself? Or do we have a true strategy on getting them off the drug entirely?
Yeah. So our the way our clinical criteria is currently structured, it's intended to be a continual part of their weight management, right? So, the lifestyle management, the weight management, that's needs to be continued.
Yeah.
Maybe for at least right now we have a year, right? But then in a non-formalized approach thereon. So then becomes a learned behavior, right? Maybe they don't need a formalized program. So that continues. And whether they need the GLP-1, we don't prevent that going forward.
Got it. Great stuff. Getting a question about the survey, Jess, just to make sure I double click on that. Maybe it's make sure that we're sending them the right link to the survey. I'm going to summarize some things I heard today, folks, on the episode, and then I'll ask my panel to jump in if I missed anything. And I'm not covering every single thing we just covered the last 58 minutes, but PA programs, all good ones and ones that are sort of have the right intention here, have wraparound support services around lifestyle change management. An example that was given by Marty early in the show was, hey, join Weight Watchers at your own costs and be part of that program and show us that you really mean you're committed to this and we'll commit to you by paying for these drugs. Secondly, I heard a big theme around integrated whole person care, especially like a lot of folks, right? We think about diabetes, we think about weight loss, we think about hypertension, but we're not thinking about musculoskeletal. And what does that mean? And the risks associated with falls and all the potential escalating costs if you don't take care of the true whole person. And we talked a little bit about mental health. I know that's a big underlying theme here. It could be an entire episode. I think it was Dr. Grant who talked about CBT, but that's big, right? Whole person care, integrated whole person care. Is the only way to even come close to earning a positive ROI here. So think about that investment, commit to that investment. And it was alluded to by a bunch of our guests today that primary care is the key to be the point guard or the QB, if you will, depending on what sport you prefer, in making all this go around. He was also an underlying theme here that I'm going to call out is adherence is an issue. Even for those who get approved, this is an invasive drug. It causes things like nausea and other side effects. And I think it was mentioned at the very beginning by Ilona that sometimes people have a huge gap between doses, and that's going to cause all kinds of problems, muscle loss, fall risk that Dr. Grant referenced. You need to think about how to make sure folks are truly who get approved and are going to go into this program stay on the drug. Incentives work. We heard about one program converting points to dollars, and the range for the PA program seems to be between 30 and 40. I know it's a large range of BMI, but that's what I heard. Anything else to add as we hit here at the top of the hour that I missed? All right. Well, listen, I want to thank everyone who tuned in today. We don't take the time that you spend with us for granted. We know you're really busy. To carve out an hour on your weekend while you're walking through the airport, or if you're watching live right now, we know is a privilege, and we hope you use the bright spots that were shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us, right? We're all patients. We do produce this show for all of you. And remember, this is your Bright Spots in Healthcare podcast. Thank you very much, everyone.